Hi, Manoj?
Yes.
I've got a question. With regards to the sacral epidural, the biplane technique is very nice. The issue that I wanted to ask is how far caudal should the entry point of the needle be when you're doing the out of plane localizing approach? Because
Question.
if it comes in too obliquely, then sometimes it bumps up against the bone.
My answer to your question would be is to go as caudal as possible and start your transverse scan. So imagine you're near the coccyx. Okay, you're coming up, and then at a certain point, you will see the two conua will just appear as two bright dots, right? And that tells you where the caudal end of the hiatus is. In the elderly patient that you're dealing with, there's probably not as wide as in children. So if you go cranially, you will now see the median sacral crest of the sacrum. So my advice is you perform a scan at the coccyx and move it cranially till you start to see the two conua, and then optimize your image there and place the center of the ultrasound probe at the center of where you see the image, and place your needle out of plane. Now, it's so simple and stupid because now you are right at the center of the hiatus, and you insert your needle, you will see it immediately inside the epidural space. You then turn your transducer and gently guide your needle into the canal, if you may, because now you're in the blind side of the posterior table. So then you use your fluoroscopy or whatever you use before you inject your steroid, I suppose. Then you can do that. I find even in children where the imaging is so good, doing it this way, I find success in the first attempt is achieved every time. Because the issue that one has to understand is that when you do a scan, even if it's a sagittal scan, it's a 1 millimeter plane. So you don't know whether you're on the lateral side of the hiatus or on the inferior side of the hiatus. So whereas if you do the transverse scan in 3D, you know that this is the center of the hiatus. And once you insert your needle into the caudal space, turn the needle transducer sagittal and search for the needle. And once you see it, you're home. So don't tell anybody this secret, Kenneth. Any more questions?
So we've got two similar questions from two different attendees. One is Dr. Afik Saimi, and the other Dr. Sandeep Mutha from India. They're both wanting to ask about the dosage and volume of drug for SA for patients with kyphoscoliosis because of the possible unpredicted spread and also the risk of patchy block or unilateral blockage. So do you have any experience to share with us?
These are extremely good questions. I think as an academic, I don't have an academic answer for you, put it this way. There are no studies to say this is what you should be doing or what has to be done. I think often it's a case of using common sense. Now, when I do them at the L5, S1 level, and you're using it primarily for, say, hip procedures, etc., then in our, say, Hong Kong Chinese patient with a habitus very similar to most other Asian community, we would not inject more than maybe 2.6 mils of local anesthetic. And this, yes, it produces up to T10, sometimes even higher. I'm happier to handle hypotension than no anesthesia in some of these cases, if you may. So what do you do to overcome unpredictable spread? This is something I haven't got an answer for you. Yes, because of the twist and turn in the spinal canal, your prudence would dictate that you are going to expect some unpredictability in the spread. But when I'm using it for surgical anesthesia, I am prepared for that. And I just use the volume that I mentioned to you. I often tend to use a hyperbaric solution. So hyperbaric bupivacaine is my drug of choice in these cases. And I use about 2.6 mils. Now, one has to remember that as you go down the thecal sac, and we talked about this at length during our webinar one, is that there are some pharmacodynamic issues when you are injecting into the thecal sac at the coda at the L5S1. Actually, there's a lot of tissue, there's a lot of less fluid in that area. But to say that there are MRI studies where they have segmented fluid and tissue, they don't seem to show a statistical significant difference. But in clinical practice, you will find that there is not as much fluid at the L5S. It's common sense because your thecal sac actually tapers as it gets to the L5S1. Your coda equina is tightly packed within the thecal sac. So that's why you get a lot of paresthesia. And when you perform a spinal, particularly in the lateral position, you may not always get CSF efflux. So these are some pointers for you, but I don't really have a very scientific answer for you. I inject about 2.6 mils and expect that the level would be variable.
Okay, thank you. We've got another question regarding the frequency of the transducer that you use to scan the spine.
So this person was obviously not there during our webinar one. For you, it's 2 to 5 megahertz. We use a low frequency transducer. And because it gives you penetration, and today with our current technology, even these low frequency transducers give you exceptionally good quality of image. And the divergent beam is desirable because it gives you a wider field of view. You can imagine if you use a linear transducer and you go deeper and deeper, your field of view becomes narrower and narrower. So for all neuraxial interventions, low frequency probes are the norm, or is the norm.
Okay, thank you. Then we have a question from Lin, Dr. Pak Pirom from Thailand. He wants to ask, in case we're not familiar with real-time ultrasound spinal block, do you think to use Prescan to identify insertion point for, I presume he's asking about scoliosis patients. So what if yes, if we use a Prescan, what would be the insertion point that you recommend to mark on the patient skin, whether it's on concave or convex side, and also how to determine the needle trajectory?
Right, Lynn, you always ask a difficult question. Anyway, I think that's a very important question. I think the answer to that would be you perform a scan and the view that gives you the best view of your target, whether you are aiming for L5S1 or L345, should be the window you should use. If you are obviously, you put your markings relative to that. If you're doing a paramedian sagittal view, then you put a paramedian mark. And if you have that information in your mind's eye, then hopefully when you do the intervention, you will perform the intervention relative to that SP line. So joining up that SP line, as you see, I religiously have put marks on all the spinous processes and have joined them up together just to give me that visual that I'm always staying relative to that line. It's very easy to lose focus of where the center is or where the spine is when you put your drape. Once you place your drape and your sterile covers, you lose the focus of where the structures are. And in order to be accurate, drawing it out as I have always told you and taught you, you do it and you perform the intervention relative to it. Of course, if you are doing patients with scoliosis for spinal interventions, then I suppose you should be trained in doing real-time intervention. Otherwise, you should ask somebody who maybe has the experience in your hospital to do so. If you don't have one and you just do a preview scan, then I would suggest you do at L5S1 level if it is open, and place a marker where it is best seen and insert the needle from there.
Thank you. I don't think we have other questions for now.
Okay, so I think it's been a great few hours, I guess. Thank you, everybody, for joining in from wherever you are in this world. My thanks again to Kenneth. You've been a star, mate. Your contribution has been exceptional, and I'm sure it will help many more clinicians around the world, because after the end of this webinar, we will load it up with your consent, of course, to some educational platform where folks can visit and learn these tips and tricks. Again, on the people in the behind the scene who are getting all these things going, thanks to Brian, Ranjit, and the rest of them. Also, thank you, Rossini, for spending your time with us this evening, and hope you also learned something with all of us. We've also learned a lot. Thank you all. Jamie, if Jamie is still around, thanks to Jamie and Brandon for joining in, and adios to you all till I see you in 2 weeks' time. Thank you.
Thank you.
Bye-bye for now.